So welcome to our third session that has been focused on really issues that we think are important to caring for people within institutions. And as I mentioned, this has been sponsored by an endowment given to for geriatric care from the School of Nursing. Just a little bit about our Caring for the Caregiver program. Our missions to support the health and quality of life of family caregivers and their loved ones. And just our vision, a community where family caregivers are valued, respected, and supported with compassion, and then committed to social justice, collaboration, and family-centeredness in our service and our research. So as I mentioned, this is part of continuing education, and you can receive I think it's a 2-hour, a CE for nurses or social workers by logging on to the Lifelong Learning Center, and I think it's $25 to receive the CE. And the University of Texas Health Science Center is accredited as a nursing continuing education development center by the American Nurses Credentialing Center, and then also for social workers. And then just that in terms of the committee that planned these, which was Jennifer Brackett, myself, and Kimberly Cox from Lifelong Learning, we have no disclosures, and similar to Laura Novak, who's giving this session today, no disclosures. Sorry, I have to say all that. And then the continuing education statements, and I talked already that they're approved to present these, and we have no commercial interest, financial or in kind, for this activity. So now to the good stuff, to introduce you to Dr. Novak, who is an experienced, amazing occupational therapist. We've been working with her, had the privilege of working with her for 2 years in the Caring for the Caregiver program. She provides an evidence-based practice in the community called COPE, Caring for People with Dementia in Their Environments. She also works and helps us in our program. So we're really fortunate to have her and her in-depth experience. She also works at the Glenn Biggs Institute for Alzheimer's and Neurodegenerative Diseases, is part of a collaborative practice there. And she's also teaching at the School of Health Professions in the Department of Occupational Therapy. And she is a vocalist and a pianist. Really, I learn so much from her every time I hear her speak. So I'm pleased to introduce you to her. But before we go ahead with that, I had mentioned to you, Sharon, but we'll make sure you get our newsletter, but we offer events monthly for family caregivers. We often have others attend as well, people who are caring for caregivers. And so we have an Essentials on December 10th, which is around legal and financial planning, given by an elder lawyer in our community who's really talented. We have a Learning Skills Together workshop, which really meets a need in the community to teach caregivers, family caregivers, how to provide hands-on care. Often they're doing this with little or no training, learning by trial and error. So we present this monthly. We're actually evaluating it through a research study right now to look at, are we really increasing caregiver confidence? And then we have a memory cafe. Jennifer, you were probably going to talk about this stuff at the end. I went too far, didn't I?
Okay, we can talk about it again. That's good.
Yeah, I'll let you go through it again. And then I also just wanted to mention the survey that I'm going to send around to you about the impact of COVID-19 on dementia care. So I'm going to stop sharing my screen, and then I'll let Jennifer finish up that. And without further ado, I'll turn it over to you, Dr. Novak. Thank you.
Thank you, Dr. Wright.
Okay, thank you, Carol, Dr. Wright. Thank you all for being here. It's nice to see you all. I'm going to share my screen now, and then we will get started. So just a little bit of background about me. I don't share this a lot, but I think I will today, just kind of letting you know how I got to be where I am today. Back in college, I had no idea what I wanted to do with my life. I was in a psychology class. I was actually a psychology major, and somebody mentioned occupational therapy, that she was applying to OT school. And I had never heard of it. I was like, well, what is that? Tell me about that. And the more she told me about it, I was fascinated by that. I thought, ooh, that sounds really neat. I want to do that. So I finished getting my prerequisites for that. I was applying for that, but I knew I kind of had, to be honest, a little bit of a fear of working with the geriatric population. I'd never been around that population and I was a little fearful. So I thought, well, I need to go learn how to do that before I can be a good OT. So I found a nursing facility that was hiring CNAs on their skilled unit. And I worked as a CNA for the next 8 or 9 months on the skilled nursing unit while I was waiting to start occupational therapy school. And I think I can't even tell you how life-changing that was, because that's when I said, this is my population. This is where I want to be. I love these people. I found so much personal value in looking at their pictures on the wall. And I just thought, I think I'm good at bringing honor and respect to their lives. And I want to do that. Like, what an amazing opportunity to do that. So that's when I decided that this was the population that I was meant to serve. So I went to occupational therapy school, worked about 16 years as an OT. I would say probably 10 of those years in skilled nursing and long-term care. I've done acute rehab, I've done outpatient, I've done home health, I've done, but probably 10 of those years have been in skilled nursing. So I'm very, 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 very familiar with the challenges in long-term care and the challenges faced by caregivers when working with people with dementia and working with those behaviors. And, you know, the occupational therapist, a lot of times we get those referrals saying, you know, Mrs. Jones keeps falling because she keeps standing up from her chair, or, you know, Mr. Smith is refusing his shower and, you know, what can we do? Or so-and-so is taking food off of everybody else's tray, you know, those types of things. So I've kind of learned over the years how to address these things. Then back in about 2015, I think, the facility I was at hired another occupational therapist to come in and consult with the entire building on how to improve our care of persons with dementia. And it was a very systematic overhaul of everything. And boy, did that open my eyes to, wow, we're really not doing a very good job. You know, and so that really opened my eyes to look at it. It's not about what the OT is doing. It's not even just about what the nurse is doing or the family members doing. It's about how the dietary staff is interacting with that person, how the laundry staff is interacting with that person. Everybody needs to understand how to interact with these people in order for them to function optimally. So at that point, I kind of realized, okay, we can do better. We need to do better. So I decided getting my doctorate would be a good idea so that I could then work in a place like this Caring for the Caregiver program, where I actually have the opportunity to really pursue this more and go out and provide education. So that's what I did. I finished my doctorate just about a year ago, and I had the amazing fortune to find myself working in this program. So all that being said, I just kind of wanted you to understand my background. So now I love presenting on this information, but it comes from 20 years of actual experience addressing these challenges. So I'm going to go ahead and start. In the occupational therapy world, you know, everything we do under a theoretical underpinning. So there's theory behind everything we do. And one of the theories we use is called PEO. And there are 3 components of this theory. So everything we're going to do involves 3 components: the person, that person's identity, their experiences, their abilities, all of those things related to the person, the environment around that person. So the physical environment, the social environment, cultural, their socioeconomic factors. And then the third thing is the occupation. So these are the functional tasks and activities. What are they doing every day? What does their life look like? What are they involved with? What are they participating in? And that is the occupation in occupational therapy. So we look at those 3 things. So again, with the person domain, we're really looking at what does their physical function look like? What is their cognitive level? What can they do? What can they participate in? What are their limitations? What are their interests and attitudes? What's their personality type? What are their preferences? And we really want to look at all of these things prior to their diagnosis. We want to understand who this person has been their entire life. So, yes, we need to understand this person now that they have dementia, but in order to start to understand that, we have to understand who they were before. So persons with dementia may experience memory loss, confusion, loss of interest in activities, and behavioral symptoms, which may affect their ability to engage in occupations. So today we're going to talk about, so how do we remedy that? How do we help them re-engage? When we look at the environmental domain, again, we're looking at physical and social context. What does the physical environment look like? What does the lighting look like? Is there clutter? Is there too much? Is there glare? What does all of that look like? And the social context, are there people around them that maybe they don't care for? Is there a male trying to give a female person a bath and the female's terribly uncomfortable with that? What does that social context look like? The actual layout of the environment, the lighting, placement of furniture, the presence of caregivers, friends, family members, all of those things. And then the occupation domain. Again, what activities are we offering? How are we providing setup? Are we offering adaptive equipment or DME that's needed? Are we, and we're going to talk a lot about routines and the importance of routines later. What's the timing? Are we asking our loved one to take a shower first thing in the morning when our loved one always took a shower in the evenings? What is the timing of the activity? And then what are the abilities required for the task? Are we expecting too much? Are we assuming that the person with dementia can do more than we think they can at this point? Are we expecting too much? So quickly, I want to review dementia. It's so important to have a differential diagnosis. Dementia is a blanket term, and there are lots of different types of dementia. And sometimes how we approach our intervention depends on the type of dementia. So Alzheimer's disease is the most common. That accounts for 60 to 80% of the cases. And persons with Alzheimer's disease may have difficulty with memory, communication, judgment, behavior, and orientation. There's a progressive loss of function. So when this person gets sent to occupational therapy, we are not going to be able to rehab this person. This person is not going to regain these cognitive functions. We have to learn how to compensate for that loss now. It's also common in Alzheimer's to see apathy and depression. That's a very common thing. Caregivers a lot of times say, I just can't get my dad to do anything anymore. He just won't do anything. He sits in his chair all the time. So the next kind we're going to talk about is frontotemporal dementia, or sometimes called FTD. This usually has an earlier onset, so usually in the 50s or 60s. And usually what people notice first are changes in behavior and language. So often memory is preserved, but again, we start seeing that change in behavior. A lot of times, a lot of impulsivity and just poor judgment. All right. The next one we'll talk about is Lewy body disease. So persons with Lewy body disease will experience an impairment of executive function. So those higher level cognitive skills, that problem solving and that sequencing and that attention, that dual task attention, can they switch their attention back and forth between things? One of the hallmarks of Lewy body disease are visual or auditory hallucinations. So that's one of the first things our neurologists look at is, are they having severe sleep disturbances and are there visual hallucinations? Because that can be a hallmark of Lewy body disease. They also experience motor dysfunction, which is very similar to Parkinson's. So sometimes you'll see a person diagnosed with Parkinson's with dementia, and sometimes it's Lewy body disease with motor dysfunction. I think a lot of that tends to be based on what presents first, if it's motor dysfunction or if it's the cognitive deficits which present first, but these look very similar a lot of times. Vascular dementia, this can be like multi-infarct dementia where people are having a series of a lot of strokes. They may just be these small little strokes that they're having, but that builds up after a while. Or this could be the person that has had a severe stroke and now they have dementia related to the stroke. So this is a very broad category. They tend to have impaired judgment and decision-making rather than memory deficits, but of course that all depends on where those strokes are happening. This is the second most cognitive neurocognitive disease. Okay, and then there's some other types. We won't go into all of these, but again, it's just very important to know that there are different types of dementia and how we address them depends on what type it is. So that differential diagnosis is really important to seek out. There's Korsakoff syndrome, that's related to substance abuse. Prion disease, which is a very rapidly progressing disease. Parkinson's, Huntington's disease. Sometimes you will see a diagnosis of mixed dementia, and what that means is there's more than one type going on. So maybe you have a person who's had a stroke, but they also have Alzheimer's disease. So there could be more than one type happening. The unspecified is the one I don't like. If we see that, you know, if I'm working with somebody in long-term care or in skilled nursing and I see that in the chart, I don't like that. That doesn't tell me a lot. So if we're seeing that diagnosis, it's, you know, preferable to get that person to a neurologist who specializes in dementia and get that diagnosis. So when we're looking at the symptoms of dementia, first of all, the term ADRD, we use that term to say Alzheimer's disease and related dementias. So if you see ADRD, that means all of the dementias combined. We have two types of symptoms. We have cognitive and we have non-cognitive. Now we can classify them different ways, but that's one way to classify them. So the cognitive deficits are things like memory and learning new material and executive function. The non-cognitive symptoms, now we're kind of getting into those behaviors, those things that happen because of these changes in cognition. So whether it's physical aggression or restlessness, agitation, wandering, culturally or sexually inappropriate behaviors, hoarding, shadowing, cursing, hallucinations, or the response to hallucinations. Those are what we would call the non-cognitive symptoms of dementia. We group those together into a term called behavioral and psychological symptoms of dementia, or BPSD. So all of those behavioral components, we refer to those as BPSD. So BPSD, those are evaluated and diagnosed based on report. So the caregiver says, look, the person with dementia is doing these things, and therefore the physician will diagnose those. They're very unpredictable and they're inconsistent. So the behaviors you see this month may be very different than the behaviors you see next month. It may change day to day, hour to hour. You know, a lot of caregivers I've worked with describe it as a moving target, and that is fairly accurate. It is very much a moving target. So these can occur at any stage of dementia, and they affect up to 90% of persons with dementia at some stage. So impact on caregivers, well, caring for a person with dementia can have negative impact on caregivers' mental and physical health. We know this is very well documented. This particular study showed that caregivers of persons with dementia who have BPSD have higher mortality rates. So we definitely know that obviously there's a high, and this can be any caregivers, not professional caregivers, family members who are caring for the person, any caregivers. So let's kind of talk about why do these behaviors occur so that we can start to figure out what do we do about it. So as the function of the brain becomes more impacted, individuals with dementia experience more difficulty understanding the environment. So, you know, what they're seeing, what they're hearing, what they're experiencing, they don't understand that anymore. That becomes very challenging for them to understand. And then as their language abilities decline, it is much more difficult for them to express their needs and concerns and to understand what other people are expressing to them. So here's kind of the theory. If some of these behaviors are a result of these environmental factors, they no longer understand what's happening around them. They are no longer able to communicate with the people around them. So if that affects their behaviors, then maybe we can modify the behavior by modifying the environment. So that's kind of the underlying principle here. We can't fix the person. If a person has Alzheimer's disease, I do not have the capability to fix their brain. I wish I did. We are working on that. Right now, we can't fix their brain. So what can we fix? We can fix the environment around that person. So how do we do that? So the first thing we're going to look at is what is triggering the behavior? Like, what's causing this? Where is this even coming from? Most of the time, if there's a behavior happening, it's that person's attempt to communicate. So they are unable to communicate what's going on. So you're going to see these behaviors as a result of that. So we have to start asking ourselves, are they in pain? Are they tired? Are they scared? Are they confused? Are they frustrated? Are they anxious? Are they hungry? What in the world is going on that's causing this behavior? Now then, first thing we have to look at is this related to me as the caregiver? Is there something going on with me that I'm causing this person to react this way? Am I extremely stressed and overwhelmed, and the person with dementia is picking up on that? Is the quality of the relationship very poor? And again, this can be professional caregivers or family members. Is there a poor relationship going on? Does the caregiver have a very poor communication style? Does the caregiver need to change the way they're interacting with that person? And the poor health one is interesting because, especially when you're talking about family members, if, for example, a woman with dementia knows that her husband is having health issues and experiencing poor health, what do you think that's going to make the person with dementia feel? Probably lots of anxiety and concern about her husband, because she probably is aware that something's going on there. So is there something going on with the caregiver? So then we'd have to look at the environment. So what's going on other than the caregiver around this person? Is this person overstimulated? Is this person trying to eat lunch in a dining room with 50 other residents and they're completely overstimulated? Or is the TV cranked up too loud and that's just too much sensory input? Is the person understimulated? Are they bored? They have nothing to do and there's nothing to stimulate them cognitively or physically, and they're just bored. Is there poor lighting? And not just under lighting, not just there's not enough light, but sometimes if it's too bright, are we getting a lot of glare? Are we getting that light bouncing off the floor and they can't really perceive the floor very well? And so that's making them hesitant to walk or hesitant to move. Are they having difficulty finding their way? Are they just confused and they don't know, they maybe detect that they need to use the restroom, they can't find the restroom. So are we seeing anxiety and frustration because of that? Is there a lot of clutter? So is the person, for example, trying to eat and there's all this food and all these dishes and everything placed in front of them and it's so cluttered, they can't tell what's what. So are we seeing agitation and aggression, or are we seeing refusal to eat because they can't figure out what they're supposed to be doing because there's too much? Are they hot? Are they cold? All of those things. Think about, in the room, feel their hands. See, are they cold? Do they maybe need a blanket? Do they have socks on? Or are they too hot? So trying to figure out what's causing this. So when you are investigating this trigger, you want to ask yourself the following questions. Okay, where does the behavior occur? Is there some consistency to this? Does this always happen in the bathroom? The only time I have, trouble with helping this person is in the bathroom. Or is there no consistency? Or does this always happen in the therapy gym or in the dining room? Or does this always happen when we leave home and go to a doctor's appointment? Where is this happening? When does it occur? So that's really important. Does this only occur in the morning? Does this only occur in the evening? Are we looking at kind of a sundowning effect here where afternoons and evenings is when this person starts becoming really agitated, or is it all the time? When does it occur? So how frequently does it occur? Is this a daily thing? Is this, weekly, monthly? Is this every hour? How frequently is this happening? Who is present when it occurs? That's a really important one. Do you notice that this person becomes more agitated when her other son comes to visit? Or, when there's a CNA working, is that when she becomes agitated, a certain person working? Is there somebody around who's triggering this? And then the most important one, in my opinion, how are you responding when this occurs? This is the piece that we have the most control over. How do you respond when it occurs? So, and we'll talk more about that. So how do we even approach changing this? So first thing I recommend is that we work on one behavior at a time. So we're not gonna tackle everything. We're gonna pick that one thing that's really challenging. So maybe it's refusing to take a shower, or maybe it's in the evening time constantly getting out of bed, or what is that one behavior that's really, really challenging, and let's start there. So look at your triggers and then think about what triggers can we change? What can we control? We can't control everything, but what can we change? And then always start with looking at your communication strategies, because sometimes changing our communication strategies, and again, our response to that person, that can be the most effective thing that we can do. So try one strategy at a time, give it a little bit of time to evaluate it and modify it as needed. So again, this is not a quick fix. This is not, we're going to do one thing, done, behavior's modified. No, that's not it. We're going to have to take some time and figure out how to do this. So you may need to try a strategy for 1 to 2 weeks before you see any kind of difference. So yes, that can be frustrating. But again, if we can get to the root of what's causing the behavior and how we can modify things around that behavior, then you can start to generalize that to other things. So as I've already mentioned, communication is very much key. We want to speak slowly. The person with dementia needs extra time to process what you're saying. So we have to avoid the temptation to say, are you hungry? Mom, mom, are you hungry? Mom, are you hungry? Are you hungry, mom? You have to give mom time to respond, okay? The person with dementia might take, I mean, I've had people take, I had a gentleman not too long ago actually, and literally I was timing it. It took 2 minutes for him to respond. But once I figured that out and I backed off and gave him his 2 minutes, his responses were usually completely accurate, but it took him 2 minutes to respond. So again, once I figured that out, I was able to say to the wife, aha, he needs 2 minutes to respond to you. And boy, that feels like a long time when you're sitting there waiting and waiting. But again, in this case, he was able to respond appropriately when he was given enough time. So, you know, I have on here allow at least 5 seconds after each phrase, because that's what was recommended in my resource. I don't even think 5 seconds is typically long enough, but at the very least, allow 5 to 10 seconds, you know, after each phrase, and give that person a minute to respond. Most likely you'll need even longer than that. So you always want to address the person by name and introduce yourself as needed, even if you're a family member, even if it's your mom, even if it's your spouse. You know, and when I say introduce yourself, I don't mean go shake, you know, your spouse's hand and say, hi, I'm Laura, I'm your wife. No, but just say, you know, hi, honey, it's Laura, I'm here now. You know, something like that to give that person that cue of who you are. And then certainly if you're a professional caregiver, don't ever assume that you don't need to reintroduce yourself or mention your name. So we want to use very simple verbal commands, break each task into simple steps, and be very specific with your prompts. So we're going to avoid abstract. So in other words, I'm going to avoid walking in and saying, okay, you need to get out of bed. Because the person with dementia may know what that means, but they may not be able to formulate a sequence of steps and make that happen. Okay, so they may know what you want them to do, but that doesn't mean they can make that happen. That's very abstract to say you need to go get out of bed or to say you need to go get dressed. Okay, well, they may still be able to conceptualize what getting dressed means, but there's a lot of steps involved with getting dressed. And they may have no idea how to start that and how to sequence that. So you need to be very, very specific, such as sit here, put your hand here, hand them the shirt and say, put this shirt on, you know, put these pants on. So very, very, very concrete, and keep it broken down into a lot of simple commands. Now, we do always like to give people choices, okay? Sometimes, I don't know if any of you've experienced this, but if you say, Mrs. Jones, are you hungry? 9 times out of 10, you're gonna get no, 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 no. Do you need to go to the bathroom? No. Would you like to go to the activity today? No. So, because again, that's very abstract. What does that mean? So instead, you want to offer very concrete choices. So we're not going to say, what do you want for breakfast? Or are you hungry? We're going to say, it's time for breakfast. Would you like eggs or would you like toast? So what we're doing with that is we're offering that cue that to get their brain thinking in terms of, yes, it's time to eat. We're still giving them choices, but the choices become very, very concrete. So again, we're taking that abstract out of there. Just because Mrs. Jones answers no when you ask her if she's hungry doesn't mean she's not hungry. It means that that abstract concept, Mrs. Jones isn't really able to properly make that determination about whether or not she's hungry and answer you properly. So we want to avoid those open-ended questions. So we also want to be very encouraging. So we want to use positive reinforcement, you know, such as take your time and you're doing great. Or if you're starting to notice some anxiety and frustration, reassure the person, say, it's okay, everything's okay. I like to add the last one in because, you know, we know that sometimes bathing and grooming can be a big issue. So I like to encourage people that when they do groom and when they do take a shower and brush their teeth and do those things, lots of positive reinforcement. Lots of, oh my goodness, you look so beautiful. You smell so nice. You know, oh, you look beautiful with your makeup on, or, oh my goodness, you have your cologne on. It smells so nice. So lots and lots of positive reinforcement. At all costs, we want to avoid negative approaches. So we, unfortunately, we see this a lot, and especially, kind of see this with caregivers or with family caregivers. And I think the reason is because, if it's your spouse, a lot of times people have known their spouse for 50 years, and sometimes it's hard to make that shift to my spouse can't help this. So we have to help those people kind of learn that, okay, he can't help this, and therefore arguing with him or trying to show logic probably is not going to be effective. So we want to avoid arguing at all costs. If you say to your loved one or the person with dementia, you say to them, it's time, we have to go, it's time to go to a doctor's appointment. And they're saying to you, I don't have a doctor's appointment. Then arguing is probably not going to do any good. A, you're not going to convince them because they believe what they believe. Their world is their world, and you're not going to convince them otherwise. And B, all that's going to do is cause lots of frustration. So we want to avoid that arguing, and we want to avoid logic of, it's time for you to take a shower. I don't need to take a shower. Well, you do need to take a shower because it's been a week since you've had one and you're starting to smell, and those types of things. That logic probably isn't going to do any good. Now, sometimes, especially if a person's in an earlier stage of dementia, that it can, sometimes people have success with saying, well, I'm starting to smell you a little bit, let's go get you cleaned up. But for the most part, trying to use logic, it's just really not going to do any good. Again, all it's going to do is cause more frustration. And that holds true especially for a person with like Lewy body disease. Maybe if they're experiencing a hallucination, if you try to reason with them about that's not really there, that's just going to frustrate that person because those hallucinations are 100% very real to them. So we want to avoid trying to talk them through the logic of, well, it's not really there. Why would there be a purple unicorn in the living room? That makes absolutely no sense, because to that person, it is absolutely real. And it's just frustrating to them that you don't believe them. So we have to kind of work around that, use a lot of things like redirection and working around that. We never, ever want to scold a person with dementia. So we never want to, I have an example of somebody saying to me once about his mother that, well, she's going to act like a 4-year-old. I'm going to treat her like a 4-year-old. And I had to say, whoa, hold on, wrong approach. We're not treating anybody like a 4-year-old. So we want to avoid scolding, again, go back to that positive reinforcement. If we're getting a negative behavior, we need to find ways to redirect, but then wait and give that positive reinforcement. Anger. If you as the caregiver are starting to feel angry, you've got to stop and take a deep breath and get yourself recentered. Because what happens if you become angry, the person with dementia is going to detect that, and their anxiety and frustration is going to absolutely exacerbate. So you as the caregiver have to keep that anger level down. So we don't ever want to make fun of somebody, if they put the pants on backwards or something like that. We don't want fun. And then we also don't want to highlight their mistakes. Again, positive reinforcement. Okay, let's talk about nonverbal communication. This is a big one because we can't underestimate the power of body language. So sometimes we may be saying all the right things. Yes, good job, yep, you're brushing your teeth, good job. But what is our body language saying? So are we back there going, okay, yep, take your time. What's our body language saying? Our body language has to match what we are saying. So we have to come across as being relaxed and happy to be there with that person. It's always important to use gentle touch to reassure the person with dementia. So, and that of course depends on the person. Does the person like for you to hold their hand? Does the person like for you to rub their back? What does that person prefer? But we always want to use gentle touch where it's appropriate to reassure that person. We always want to make eye contact when possible. And, I'm a firm believer that we need to be in front of the person, but we need to squat down in front of the person. I don't like standing in front of the person and bending over, because that's still somewhat ominous that I'm this person standing up, hovering over them, looking down at them. So it's preferable to either sit down in a chair across from them or squat down and see them at eye level. For people with dementia, as dementia progresses, basically their perceived world closes in around them. So it gets smaller and smaller over the progression of the disease. It's not what their eyes visually see, it's what their brain can perceive. It gets smaller and smaller and smaller until at the end, they only perceive what is directly in front of them. So if you have a person with moderate stage dementia and you're standing behind them talking to them, they probably had absolutely no clue that you were talking to them. They may hear a voice, but the perception of you speaking to them, probably not at all. So if you're helping somebody, with feeding or something like that, you have to be in front of that person, because if you're standing beside that person, all they're perceiving is a spoon coming at them. There's very little context for what is happening here. So you have to remember that, we see that sometimes when we're trying to work with people with dementia and maybe they're hesitant to sit down on the toilet. Well, you have to remember, because the idea of that toilet behind them, that may be very abstract, and they don't perceive that there is a safe toilet behind them that they can sit on. They may not perceive that. So we have to do things to help them understand that it's there, have them back up far enough so that their legs are touching the toilet and they can feel it there. Have that grab bar where they can put their hands there and they have something concrete other than, oh, I promise your wheelchair's behind you, I promise. That may or may not be real to them, that may not exist to them. Okay, so again, back to nonverbal communication. So we want to use visual cues. We're going to offer a lot of verbal cues in terms of those simple commands of, put your hand here, put your shirt here, or put your shirt on. But we also want to offer visual cues as well. So we're going to point to the item. If we're saying, why don't you take a drink of your water? Then we would say, why don't you take a drink of water? Offer that visual cue as well. We're not going to say, okay, grab that grab bar over there. We're going to have to show them where that grab bar is. So use those visual cues to help. Sometimes you may need to use hand over hand to help help the person initiate a task. So maybe the person can feed themselves once they get started, but maybe you have to literally take your hand, help them get started, and okay, now we're good. Now we're going. So sometimes the problem may be that they can't start a task. They may know what they're supposed to do, but they can't start that task. So again, a lot of these things that are perceived as, they're just being stubborn and they just won't do it, or they just don't care anymore. It's probably not that. It's probably that they can't start that task, or they don't know what they're supposed to do. So sometimes instead of just telling them, now we're offering those visual cues of pointing to the spoon. And if that doesn't work, okay, now we're going to use hand over hand and help them get started. It's also very helpful to model the behavior you're seeking. So we have something called mirror neurons, and those mirror neurons are activated by watching somebody do what we want that person to do. So in other words, if I want my person to eat lunch, if they are watching the person across from them eat lunch, then they're more likely to initiate and eat themselves. So it kind of activates those mirror neurons that say, oh, that's what we want. So, if you're sitting down with a person with dementia to eat, it's helpful if you're also eating. Or if it's brushing teeth, it's helpful if you're brushing your teeth as well, or if you're a professional caregiver, if you have kind of a toothpaste that you use to show this is what I want, then that can be very helpful. So we have to also understand how the person with dementia, how they are able to communicate back with us. So people with dementia, they may become incredibly frustrated and agitated if they're not able to communicate what they need. So you have to allow the person time to speak. And if the person is stuck, then it's okay to try to fill in words or phrases, but just don't get too aggressive with that. It's okay to say things like, are you saying that you need to use the restroom? Or are you saying that you're cold? it's okay to do that, but try to give them some time first. Don't just jump right in there and do that. So, and then you want to paraphrase what that person has said to you to try to show them that you do understand, to make sure you're getting it right. Okay, so we also have to assess the person with dementia's non-communication as well. You know, I mentioned our nonverbal communication is incredibly important. Well, so is their nonverbal communication. So we want to look at, again, what are they physically doing? What are they trying to communicate to me? So if the person is pacing or fidgeting or becoming combative, why? What are they trying to tell me? So for example, pacing may indicate that they need to use the restroom. So if a person is pacing or becoming very restless and fidgety, I would kind of want to go through a checklist in my head and go, okay, when's the last time she's been to the restroom? Okay, when's the last time she had a drink of water? Is she due for a pain pill? Kind of go through that checklist of what could she be feeling that's making her act like this. You know, if the person is touching or rubbing a back or a knee or wringing hands, again, think about it. Okay, is she hurting? You know, and sometimes they don't have to have acute pain to start hurting. You know, if you've been sitting in a wheelchair without moving for 4 hours, yeah, you're probably going to be hurting somewhere. So we have to think about, okay, does this person just need to move? Is there pain somewhere? Certainly we would want to look at, you know, a lot of times people can still tell when they need to use the restroom, they can't communicate that. So is that what's going on? Or did they soil their brief and now they're feeling that and they need it to be changed? But then look at too, like if the person's pacing, where are they pacing? Are they pacing in and out of the kitchen? Or are they trying to, you know, is that their way of saying they're hungry or they're thirsty or they want something out of the kitchen? You know, if they're constantly going to the bathroom and out, you know, I work with somebody right now that does that, just constantly in and out of the bathroom, in and out of the bathroom. So my first thought is, could she have a urinary tract infection? Could there be something going on that's making her feel that urgency to go to the bathroom? And that's why we see her in and out of the bathroom. You know, what's going on? So pay attention to what they're actually doing to see if you can get some clues from that. You know, I kind of already covered this, but again, are there medical considerations? Is there an infection somewhere? You know, I think a lot of us know that if you see acute changes in cognition, one of the first things we suspect is there a urinary tract infection? So, you know, we need to look at those things. Has there been a change? We need to think about, okay, when's the last time this person had a bowel movement? Oh, let's see, I think it's been 3 days. Okay, they're probably really hurting right now. So we need to consider those things. Is there a new medication that we're seeing some kind of interaction? Because remember, they may not be able to communicate symptoms. They may not know what's wrong. They just know something doesn't feel right. And again, this may result in behaviors. So it's really important that you become the medical advocate and you as the caregiver monitor signs and symptoms. You know if a new medication is introduced, what are the potential interactions and side effects. You need to somewhat keep track of bowel and bladder output. You need to kind of keep track of intake. How much are they eating and drinking? Are they getting enough water? Are they dehydrated? Kind of just paying attention to those things. It's a lot, but you know, again, those are the things that are going to give you clues. So, I'm a step ahead of myself on everything today. So again, be aware of continence and are there changes in continence happening? So if the person is maybe having a change in continence, see more and more frequently, that may be why you're seeing that agitation. Okay, this is very important. You as the caregiver have to manage your stress. And again, I've been a CNA in a facility. I've been an occupational therapist in facility. I understand. I have not been a 24-hour-a-day caregiver for a person with dementia, but my mom has. So, you know, this is almost kind of, you know, perfect world scenario. Yes, manage your stress. But there are some very, very simple things you can do to try to help your stress in that moment come down a little bit. So it's very important that you maintain a calm demeanor, okay, when you're working through a challenging task, because if you don't, it's just going to make it worse. It's just going to exacerbate that. So again, remember what we said, that dementia is going to perceive your stress and frustration and react to it. So if your tone of voice and body language are starting to change and become more aggressive, then the person with dementia is going to respond with increased behaviors. Okay, so how do we do that? Okay, here's my perfect world scenario. All right, find time for yourself. Engage in activities you enjoy. Attend to your physical well-being by keeping your healthcare appointments, taking all medication. Now that one's not perfect world scenario, that can be done. Try to get daily exercise, eat good healthy foods, and try to get plenty of sleep. Again, I completely understand if you are a 24-hour caregiver, some of these are very, very challenging, but be mindful of these things and do the best you can. You can control the food you eat, and you can control taking your medications. And if you're struggling to find ways to engage in activities you enjoy, then that might be a time that you seek out some professional help, whether it's from a counselor, an occupational therapist, a social worker, somebody who can kind of help you find ways to do that, help you find some options. Now this is, I like these because these are things you can do even if you are a 24-hour caregiver. These are things that you can implement with the person with dementia still there. So use music. Music can absolutely calm both of you down, right? So just play nice, relaxing music. The use of visual imagery. I love that. If you and the person with dementia are just having some time just sitting on the couch watching TV or whatever, this is something you can close your eyes and do some visual imagery and try to, imagine that nice relaxing beach, something just to help you calm down a little bit. Same thing with counting exercises. Going for a walk or, doing yoga. I mean, we can pull yoga up on YouTube all day long and just kind of take a 10-minute deep breathing, meditative, very simple yoga exercise. Using things like progressive muscle relaxation. And then the deep breathing. Here's the thing about deep breathing. You do not have to go into another room. You do not have to walk away from the person. All you have to do is in that moment, stop and take a few deep breaths. Okay. If you feel your anxiety, your frustration, your stress starting to rise, if the person with dementia, if the behavior is getting worse, what are we going to do? Okay, we have to just take a few minutes and breathe, get ourselves brought back down first. And I think it's very important to do that too when you are going into what you know is going to be a stressful situation. Maybe, okay, it's time, it's shower time again. Okay, here we go. This is going to be tough. I know it. Then do that at a time when you have time to allow yourself to slow down a little bit and breathe, and do that deep breathing before you ever get there, so that you go into it knowing, I know this is going to be challenging. My stress level is down. I know this. I'm good. Let's go. Let's do it. Don't try to do the shower when you only have 30 minutes because we have to be out the door for a doctor's appointment. That's not the time to do it. So you have to go into that activity ready for it. Okay, routines. Let's talk about routines. It is extremely important to help the person with dementia maintain consistency. Okay, this is not a schedule. Okay, this isn't at 8 o'clock we're having breakfast, at 9 o'clock we're doing yoga, at 10 o'clock we're going for a walk. This is not a schedule. This is a routine. So this is consistency and kind of the order of things. Okay, so maybe it's the first thing we do when we wake up is we have a cup of coffee. Okay, then after we have our coffee, then we're going to have breakfast. Then after we do breakfast, then we're going to go brush our teeth and put clothes on. Consistency. Okay, then and that needs to include rest breaks. You don't have to, the person with dementia doesn't have to be engaged all the time. They're going to get tired. They need rest breaks. Build those rest breaks into that routine as well. Build exercise in, build socialization in, so that, okay, every afternoon we're going to do some kind of social activity, which is challenging right now, but something, maybe we're going to FaceTime with grandkids or something like that. It doesn't have to be the same activity every day, but something that kind of fits into that category. The routine should 100% be based on what the person with dementia is used to and what's going to work best for everybody. So again, if you're seeing a lot of resistance to taking a shower, but you're trying to give that person a shower at 2 o'clock in the afternoon, the context for that person, that makes no sense. Why would I be taking a shower right now? That makes no sense. So find out, did that person always take a shower in the evenings or always take a shower in the mornings? Well, if they did, then maybe let's try changing it to when that person is used to doing it. It makes more sense. That person always showered after dinner before she went to bed. Okay, well then it makes sense that that's what we would try. That's going to make more sense to that person. you know what that person is used to. And if you don't, if you're a hired caregiver, professional caregiver, get with the family and say, tell me about this person. What were his preferences? What did he like to do? How did he do this? Sometimes I'll work with people, and I'm working with one right now, and turns out his entire working life, he never ate lunch, ever. So guess what happens when we try to get him to eat lunch? He's not gonna eat lunch. And that's not him being obstinate or difficult. He never ate lunch. So it makes no sense to him to eat lunch. That's not what he knows. So again, something that could be perceived as a behavior of him flat out refusing, it's really not a behavior at all. This is what he was used to. But by knowing that now, we can go, oh, okay, let's reframe this then. It makes no sense to him. So consider placing the difficult task at a time when the person with dementia is at their best. Maybe we're not going to try. I always encourage people, try to avoid the doctor's appointment at 8 a.m. That's not always possible, but when's this person at his or her best? Is it at 10 a.m.? Okay, then let's shoot for the 10 a.m. doctor's appointment. Let's not do the difficult things at 4 o'clock in the afternoon when this person is exhausted and wiped out. Maybe we need to schedule the shower, whether it's in the morning or in the evening after that person's had a rest break, had a period of rest, when they're not overstimulated, when they've had some downtime. So again, this is a routine. It's not a schedule. There has to be flexibility. As we all know, what works one day may not work the next day. So there has to be flexibility with that. But the point is that it's very consistent so that it makes sense to the person over time, that this is what we're doing and this is how this is going to go. So again, you have to modify those routines over time. So this is kind of an example of what a routine might look like. And this is, I know that can be very, very challenging at times, but it's so important. Again, if you take these steps, it's really going to make a difference in the long term about addressing these challenges. So, okay. And then here's the one, as an occupational therapist, that is near and dear to my heart. As human beings, we need to participate. We need to do something. Right? We don't want to sit all day. We need to do something. The same thing is true for a person with dementia. So sometimes unfortunately what happens is, as they can't do things the way they used to, we get into this routine of they just don't do anything. I see very well-intentioned family members say, well, mom was always the cook for our family, but she, it's hard for her. So I told her, don't worry about it. I'll do it all now. Unfortunately, what you've just done is, you've taken mom's role away from her. She was the matriarch who did all the cooking. And now all of a sudden she's been told, no, mom, you don't worry about it. I will do it all now. And again, you may have the best intentions in doing that. But the reality is mom has now lost her role as the cook. She's lost her role as the matriarch. And that can be very disheartening. So what we need to try to do instead is find ways that mom can still participate, mom can still be part of this activity, maintain her role as the matriarch, as the family cook, whatever it is, but we just have to modify it. So we're going to modify how she participates, but we don't want to completely take that away from her. People need that sense of purpose, and people with dementia need that sense of purpose. Unfortunately, a lot of times we see people with dementia sitting and doing nothing. Or, I've seen it a lot too, personally experienced, where activities may be designed for people who are at a much higher cognitive level, and therefore the people with dementia aren't even brought to the activity because, well, they can't participate anyway. Well, so where are they getting their meaning? Where are they getting their purpose if they're not being included in these things? So it's 100% okay for that person. If that person with dementia is just sitting there, but maybe she's looking around, maybe she's watching and observing, maybe you hand her the craft material and maybe she's not making the craft, but maybe she's holding it and touching it. We still have that engagement. Her brain is still engaged in that activity. So, we absolutely have to modify the activity and make it simpler, but we want that person to participate in any way possible. So in any way he or she can, even if it's just sitting while you do it, maybe you're talking to that person about the activity. So, the thing is, you have to relax the rules a little bit because the benefit is in the process, not in the product. So, if mom can participate in folding some wash rags or folding some towels, I don't really care if they're folded or not. If she's picking through them, guess what? If that person was always the person who did the laundry, or she was a homemaker, or whatever it is, then she's still getting fulfillment and meaning out of the fact that she is participating in that. It doesn't matter whether the towels get folded or not. That's not the point. The point is she is getting that engagement and that fulfillment. So a lot of times we see behaviors because the person is bored and has nothing to do. We've essentially taken away all of their life roles. So I worked with a family once, and the mother was the person with dementia, and she had become very agitated on a consistent basis because she was convinced that her husband had another woman in the house. And so that was the behavior. They could not figure out how to handle this. Well, in talking with them, I said, well, what does she do all day? And it was essentially this exact scenario. She had very much been the matriarch. She was the homemaker. She raised the kids, did all of this stuff. And now the family, who was so wonderful, were going to take care of mom now. But guess what? They had taken everything away from mom. And now the kids were doing the cooking, the kids were doing the cleaning, the kids were doing the laundry. And the husband, because he kind of had a hard time dealing with her dementia process, most of the time stayed in the other room and stayed away. So what was her perception? That somebody's doing the housework, somebody's doing the cleaning, somebody's doing all this. I never see my husband. So her perception was there's another woman somewhere. And so when we changed that and re-engaged her in the process, so maybe it's the kids are going to still help with the cleaning, but mom is very much there and present and active. And maybe mom is just wiping down the countertop while the kids wash the dishes. Somehow mom is engaged in that activity again. It gave her her role back. So we have to think about, again, in that case, why were we seeing that behavior? Well, because of what she was perceiving around her. So, you have to find ways to allow the person with dementia, if that person was a homemaker, how can that person participate still? If the person is a musician, how can we engage that person in musical activities? Is it just listening to music? Is it, a lot of places we have a choir, but a lot of places have choirs, just singing, hymns or whatever it is that they still know. If the person was a teacher, they may find fulfillment in organizing things, or the opportunity to participate in something educational. So look at those life roles. What did they do their whole life, and how can I find ways for them still to engage in that now? So that is the end of my presentation. So again, just to reiterate with that, we really, so many times those behaviors are coming from a place of either there's some kind of medical issue going on, there's some kind of discomfort, the person may be very overwhelmed, overstimulated, something like that. Or again, it's understimulation. They no longer have any participation in anything that's meaningful for them. So how do we give that back to them? So, okay, well, that is the end of my presentation. So I guess we will open it up.